Hi, good afternoon. I'm Dr. Sabrina Nasrin. I'm a breast surgeon by training, and my specialty or my interest is in minimally invasive breast surgery and oncoplastic breast surgery. Thank you so much for spending the afternoon with us. So I'd like to begin by telling a story about one of my patients, one of many patients, but in summary, she was pregnant and diagnosed with breast cancer, which is a story that we're hearing more and more about nowadays, now that there are more young women in their 20s, 30s, and 40s suffering from all these diseases. So this is Ida.
At that time when I was diagnosed, I didn't know that it was possible to be pregnant. How can you be pregnant and how can you continue your cancer treatment? I wanted to find women who, like me, have similar experience. In this young women support group, there are young, newly diagnosed women who actually ask us for our experiences, and then we would share with them what we've gone through. When I started sharing on social media, there was one mummy actually told me that she found out my story, and then she always has this suspicious lump. So she went in for a check, and it was actually breast cancer, and she was also pregnant. So my story gave her some hope in the sense that the baby can be okay, even despite going through all these treatments.
Part about Ida's journey is that she had this breast lump for a year plus, and she actually had it from her previous child's breastfeeding journey all the way until we actually diagnosed it when she was pregnant with the second child. And that kind of story is actually oddly common because when young women get lumps, sometimes they're not really taken very seriously because they get swept away and we think it's breastfeeding related issues or benign issues, but a lot of times when we look in deeper, there might be something else there. So in summary, she got a chemotherapy while pregnant. After that, she managed to get a breast-conserving surgery once she delivered, radiation therapy, and now she's surviving more than 5 years and happy. So I have 5 key messages today regards to breast cancer. Firstly, let's be aware. Secondly, shall we all understand our risk a little better? Thirdly, let's get timely consults when necessary. Fourthly, we try to live well. And lastly, if possible, please do screening when we are healthy. So firstly, let's talk about awareness. So it was mentioned that breast cancer is the most common cancer in the world and in Singapore, but if you look at these statistics, actually it's quite shocking that, it's the number one cancer everywhere, taking over lung cancer several years ago. The estimated risk in Singapore is about 8.3%. And I'd just like you to look at this chart and see how much more diagnoses of breast cancer we have compared to other cancers. In fact, if you look here, if you add up colon and rectum, lung, uterus, and lymphoid neoplasms, you might even just get the number of breast cancer in total. So it's really quite shocking. But the good news is that breast cancer is very treatable, okay? In the 1970s, maybe we were getting a cure rate of about 50%, but right now we're at 8.82% in Singapore, and there are other countries that are even doing the same or maybe even better. The average life expectancy of women nowadays is about 85 years old in Singapore, so we're going to get a lot more women who are going to survive the disease, live happily, healthily to a very old age. So basically, breast cancer incidence is on the rise, so are the survival outcomes. This is consistent throughout the world, and in high-income countries, I would consider Singapore one of them, the life expectancy actually is going to be great, and the cure rate exceeds 90%. So I think we just have to be attentive to the fact that it can happen to anyone. Okay, even men, even though that rate is very low, less than 1%, but it can happen to anyone of any age, any menopausal status, any breast size, with or without a family history. And the key thing is to make sure that we diagnose them early or in a precancerous stage. So I think this is something that we all know. That's why we're here today. So as a doctor, I definitely want to aim to cure. So if I catch anything in stage 0, at the most to stage 3, definitely we're going for cure and we're going to try and sustain that. But unfortunately, if we catch a cancer very late and we've given it a chance to spread to other organs, that's stage 4 disease, then unfortunately, we still can do a lot. And Dr. C will tell you more about this, but the aim may not be so grand, okay? So my message to everybody is life's peachy sweet if you test, detect, and treat. So I'm going to go to the next point, which is let's understand our risk a bit better. Okay, so if you look at this is a QR code. There is a calculator here. There are many such good calculators that are validated, and a lot of them are online. This is a simple one. This one originates from US, and it's a worldwide validated calculator. I do mention that we don't really have a very good established Asian or Singaporean one. That's why we're using this as an adjunct, but it's actually still fairly accurate. If you put in some of your data, you're going to get a very nice computed score of your risk in the next 5 years and your lifetime to age of 90. And if you see, the time I was talking was the time you need to get actually that result. Okay, so I'm just going to move on, because basically the risk that you're putting in is going to be these factors, right? We're going to look at our personal profile, our medical history, hormonal factors, and lifestyle. And basically, if we look at personal profile, unfortunately, being female, being of increasing age, because we can garner more mutations with increasing age, these are just going to be main risk factors. Family history is a large influence, not just because of some, indirect genetic issues, but potentially because of inherited genetic syndromes as well. And these are some examples. In our medical history, if anyone was previously diagnosed with a high-risk breast lesion, we would already, hopefully your doctors would have informed you of that, and we would be very careful because the risk can be higher, about 4 to 8 times. And if there is increased estrogen exposure in our overall life, meaning to say we have our menses a bit younger, maybe stop a bit older, maybe not have so many children or not breastfeed, then this would allude to possibly higher risk of breast cancer. And lastly, in our lifestyle, and this is not just for breast, right? It's for all kinds of diseases, it's for all kinds of cancers, but basically a sedentary lifestyle will lead to increased general health risks. Increased alcohol intake will also do that. But specific to breast cancer, there's a reason, and that's because if we have more general fat in our body, this breaks down into estrogen and then again contributes based on a hormonal factor. So just a ballpark, this is what if you calculate it, if you get an average risk, which means less than 15%, generally speaking, then you're kind of okay. We just have to follow the national guidelines. But if you get a high risk, more than 20%, then there's something else we need to look into. There's always an intermediate risk zone. Some people may fall into that, usually because you may have maybe some family history, but maybe not amounting to something extremely dangerous yet. We will talk further. You can see a breast specialist and maybe they'll advise a little better. Okay, but for those with high risk, okay, the next step would usually be a genetic counseling session and testing. And at IHH Mount Elizabeth Hospitals, this is always done in a multidisciplinary setting, usually with the team of genetic counselors, or medical oncologists, and anyone else that is interested in your welfare, basically going through the pre-test counseling, consideration of the most important test to order, and definitely once you get the result, do a very good post-test counseling and subsequent follow-up. So the genetic test results after taking a blood test can come back positive for genetic mutation that leads to increased risk of cancer, can come back negative and you're reassured at least you don't have extremely high risk, or sometimes come back as in between, a variant of undetermined significance, meaning to say that there is a mutation, but maybe right now we don't understand completely the implications of that yet. And with more research, someday maybe we will have more information. But basically, for breast cancer, what we are majorly concerned about is the potential for hereditary breast and ovarian cancer syndrome. And one of the most common conditions that may lead to this is a condition called BRCA mutation for BRCA1 or 2 genes. Actually, this does not affect the predominant number of women. This is actually usually only happening in 5 to 15% of breast cancer patients. Most of them are just going to be sporadic or happening because of other chance factors, environmental factors, and so on. But if one is diagnosed with a BRCA mutation or a family member is, then we will be very attuned to checking for not just breast cancer, but ovarian cancer, pancreatic cancer, melanoma, prostate cancer for the males, and other cancers as well. And if you look here, this is because the risk of cancers escalates actually quite significantly. And for breast, it can go up to 47, 67%, and some studies even show up to 80%. So we may have to get on board to do preventative care. This could be surgery to remove the breast preventatively. This could be in terms of medication to lower our estrogen in the body. But in summary, that's the risk. I'm just going to move forward now to, if you have an issue, please come forward and do timely consults. The most common symptoms that I'm going to see in the clinic are going to be, firstly, the breast lump. After that, things that are tend to be in conditions that may be a little bit more progressive, like when there's skin changes, like dimpling, redness, ulceration. Cutie orange is like a edematous appearance where the skin appears puckered. Sometimes the cancers are nuclear near the nipple and affecting it, so the nipple can retract. You can have rashes and ulcerations that develop around the nipple, or if it leads to a duct, it can also cause nipple bleeding. So these signs should alert you to something that needs to be evaluated. And if you come forth and see a breast specialist, most often we're going to do a thorough clinical evaluation, assess your risks, execute some breast imaging like mammogram, ultrasound, maybe an MRI, and when indicated, when something looks wrong, you may be offered a tissue biopsy. So moving forward, let's say we get a biopsy and there is cancer diagnosed. In the breast, we have breast lobules that produce milk, breast ducts that lead the milk to the nipple. So the most common place where cancer cells mutate and can lead to cancer is in the ducts, arising to invasive ductal carcinoma. The next most common is going to be invasive lobular carcinoma. Of course, there are many other specialized subtypes, some favorable, some less favorable, but this will be clearly diagnosed once you get a biopsy that alludes towards a cancer diagnosis. I want to take a moment to tell everybody about how something may progress from benign all the way to a cancer. And this is just a simple diagram just showing at the bottom ducts. So when we are born, we have, this picture shows basically a tube like a duct where milk flows in the center. And in a normal person, you're going to have a ring of normal cells around that area. With time, as we age, maybe the cells multiply, you get a few more cells. So that's hyperplasia, which is still a benign diagnosis. But one day, if there is a critical mutation that leads to a cancer change, then that's going to be the atypical hyperplasia, which is right in the center. Atypical implies the cell is already appearing to be cancerous. Hyperplasia means at a more than usual amount, but it has not reached cancer stage yet. And this is important because this is a precancerous entity that can be eradicated and you can stop the process right here. But if left to fester because we didn't know it was there, then it might lead to stage 0 cancer, whereby the cells are still contained within the duct. And if, again, allowed to break through the duct layers, a medical term known as basement membrane, and then cause a mass, and you're going to have invasive cancer, which is our formal stage 1 to stage 4 cancer. So basically, if we are able to diagnose and intervene in anywhere earlier in this time point, we may even prevent the disease altogether. So I'm going to talk a little bit more about this in screening later on. But basically, once a cancer is diagnosed, your doctor should look to tell you about a little bit more features. Like, for example, the grade. Grade is looking at each individual cancer cell, seeing how dangerous appearing the cancer cell itself appears. If it's a low grade of change, it will be a stage grade 1, moderate, grade 2, high grade of change, grade 3. Of course, we don't really want to see a high grade. We obviously prefer to see something low grade. We will also check subtypes, and that means in breast cancer, 3 receptors on cancer cells. The estrogen receptor, the progesterone receptor, both of these are hormone-based receptors, and the last one is known as the HER2 receptor. And basically, with this information, your doctor will look through everything and maybe advise what type of subtype this is. Most commonly, it's going to be the hormone-positive cancers, which are more easily treatable. They tend to move around less, they tend to spread less commonly and recur less. But occasionally, we will diagnose the HER2-positive cancers or the most aggressive triple-negative cancers that may need a little bit more treatment in terms of systemic therapy, like chemotherapy, target therapy, and other therapies to control. So all this information is going to be required. The next thing your doctors may do will be to do additional scans to see whether the cancer has spread. This can be sometimes the MRI of the breast or a PET scan, CT scan, bone scan, just to see where the disease is. And obviously, we're much happier if it's contained in an early stage. The last thing as a surgeon I do is I make sure that I really understand each individual's body type, and not just the breast, but the rest of their body, right? How their contours are like, what their personal preferences are like, sometimes their gender orientation and things like that, so that we know what to do eventually. And lastly, the most important thing in my book is personal choice. Because all women in different parts of their life, whether they're young, whether they're older, they are in a different phase of career, a different phase of family planning, maybe just getting married, maybe already established, maybe have grandchildren. Their priorities are totally different. So there are a lot of things to look into, all the way as simple as fertility, body image, whether there's additional menopausal concerns, whether they're just building the career and it got disrupted. So all these things are important. How much treatment they're willing to undergo, how extensive, how concise, what they want. That is actually the most important thing. But as of any cancer, breast cancer is also very much a multidisciplinary collaboration. So I work together with all my colleagues, my very good colleagues, my medical oncologist friends, my radiation oncologist friends, specialist nurses, physiotherapists, psychologists, genetic counselors, to make sure that all the treatment is planned strategically, systematically, and it's perfect for each patient. When we look at treatment, this is basically the general overview of what patients may undergo for breast cancer, all the way from surgery, radiotherapy, chemotherapy, to all the other drugs down to immunotherapy. And basically, the order should be very well thought out. In the past, surgeons used to believe that we do surgery and then pass the patient along to everybody else to treat. But nowadays, we know that we have to really much understand the biology, the nature of the cancer, so that we can decide if there's a better way to treat the patient. Whether we should send them for some chemotherapy and systemic therapy first to shrink disease, contain it, augment things so that when we do the surgery, it will be more effective and maybe, possibly, very strongly even lead to a survival advantage. So this is things that we're going to iron out for each patient, and the journeys are always going to be different from individuals. So you can't really compare one to the other. But I'm going to focus now on surgery because that's obviously my pet topic. So I'm going to share, these are my two interests, oncoplastic breast surgery and minimally invasive breast surgery, which I think are two philosophies that intertwine super nicely. Oncoplastic breast surgery is basically using plastic surgery principles and techniques to help people augment breast shapes and forms so that we preserve the appearance. On the other hand, minimally invasive breast surgery is using small incisions and laparoscopic or robotic approaches to try and get the same thing done, but in a very nice, subtle, aesthetic way. Okay, so when I study patients, I make sure I understand their morphology, their shape, size, texture, natural skin creases, and any previous scars and incisions. And then I understand where this tumor location is and the size in proportion to this, because different parts of the breast have different volumes. For example, the upper inner part, which is that little blue area in the center, is always the flattest area with not so much volume, but the upper outer quadrant and lower outer quadrant is fuller. So if you have diseases there, maybe removing them will appear more subtle. So these are things that I balance. And then I look at the tumor to breast size ratio, and I have a ballpark understanding in my mind what's the percentage. A bit like going to the market, but a lot more precise than with experience. So, for example, if the breast tumor to the breast ratio is about 10%, that's quite small, then I can easily remove it without disrupting anything. But let's say it goes up to 20%, 30%, then obviously the way I plan might be different, and I may need to take in some of my opinions whether or not mastectomy is required, a partial breast removal is required, and whether I need to reconstruct. But most importantly, I will guarantee to most patients that first and foremost, oncological resection is principle. We have to make sure that we remove cancers safely and effectively, and make sure that we don't get our patients in trouble with recurrence issues. And I need to know how to predict this against side effects of other treatments that they're going to undergo, like the radiation. Will that shrink the breast a little bit? Or the adjuvant treatments, how are they going to influence things? So I need to balance all of this. But in summary, you may have heard out there that there are two main groups of breast cancer surgery, either the full removal of the breast, which is known as the mastectomy, or the partial removal of the breast, known as breast conserving surgery. Obviously, I put up there on the slide all the indications for which one may not be able to do a breast conserving surgery, but in this day and age, most patients who choose to do so will actually be eligible for breast conserving surgery as long as they're diagnosed fairly early on. So, just to show you, mastectomies used to look like this, right? We remove the whole breast. Maybe we don't reconstruct it. It doesn't look really great because you have a flat chest on one side. It's very disproportionate because symmetry is very important in life for our face as well as for our breasts. But it's not just aesthetic. It's body weight, it's contour, right? So if you have one side with a heavy breast, the other side without a breast, you actually have musculoskeletal imbalance. You're going to have back issues. You're going to have neck aches because the things are changing. It's like wearing a backpack consistently on one side but not on the other. So these are important things with life, and you will see the effects of this in 10, 20 years when it wears down on a person. So Obviously, there are still going to be some women who choose to do this because it's simple, it's good, effective, and maybe they're older, they're 80, 90, 100, right? So maybe it's not a priority at all. We just want to get rid of the disease. And even when we do this, to be fair, we can fit them nicely into bras with really good prosthesis, and nobody will be any wiser. And we'll have to just, treat the cancer as a priority. But I try not to do this surgery if I don't have to and people don't want it. Most of the time, we're going to do skin and nipple preserving mastectomies, and not just in a conventional way with a scar across the breast. We're going to work more and more about minimally invasive surgery with endoscopic approaches, robotic approaches. I want to hide scars so that it almost looks like nothing's done before, because scars are not necessarily bad, right? They're battle signs. However, Asians tend to keloid, tend to have raised scars, and some of these can be very unsightly, like a constant reminder that something was done there. Because breasts are actually a very private part of our body, but it's something that we look at in the mirror, maybe in the shower, and it reminds us constantly that something was done. So my pet topic is keyhole surgery. Instead of having incisions across the breast and in the axilla as 2 incisions, I try very hard to keep my scars in location A or B, which is in the armpit or in the bra line, so that it almost looks like nothing was done. And the third picture is exactly how it looks like on the patient. So take, for example, this. Okay, I have a lot of breast photos, but just to let you know, they're all, my patients all give permission to show because they're actually quite proud of the journeys. So if it's sensitive to you, please avoid them, but also please don't share them because it's still private, okay? So for example, traditional mastectomies, even with the skin and nipple preservation, you have scars on the breast itself. But with minimally invasive breast surgery, I'm trying to hide the scars so that you actually don't see any effects of that surgery once it's done. So moving on, for minimally invasive breast surgery, what we try to do is remove the entire breast tissue, basically taking out the entire breast through a very small hole in the armpit or in the bra line, taking out the whole breast tissue, reconstructing the breast. It can be also done with robotic techniques. And once I remove this whole thing, basically I'm going to be reconstructing that. In the theater, what we do is we make sure that all these incisions are hidden properly in patients' bra lines and creases. We make sure that we remove everything cleanly, nicely, and then there's a very good thin layer of skin left behind. I make sure that's effective, and then I go on to reconstruct the breast. We can do that in many ways, and basically we can do that with implants, which may look like this on the left side. This is bilateral for a patient in her 30s. It actually looks quite original, I think. In terms of back reconstructions for muscles at the back, I now do that with a very small cut in the axilla, only one cut instead of the big cut at the back. That's the back muscle being flipped, and basically this is the end result with a very small scar at the side. And this is another patient with some fat graft to make sure the contour is fine. And for abdominal flap reconstructions, basically we take the fat from the abdomen and we replace the breast, and for this is on the right. So in summary, a lot of patients feel that, at least their body image is not so disrupted. We also can reconstruct nerves to regain their sensation so that they can have that. But I also try my best to just do breast conserving surgeries without disrupting most of the breast tissue. So in summary, when I do that, I try to hide the scars in skin creases and natural planes. For example, in the nipple areola, in the bra line, in the armpit, so that it's not super obvious. So it looks like this in the nipple areola. It looks like maybe this in the bra line and it's hidden. Some patients have very pendulous breasts, and at the same time, we do breast reduction, scooping it up. So you actually solve a lot of issues in terms of backache, in terms of neck ache. For patients with big removals, I then take maybe the fat from the side, flip it in, and that's a flat reconstruction, and you get an original shape. So, for example, reduction mammoplasty. This is one of my patients in her 60s. Now, she's really happy because this is exactly what she showed me. This is the before and after. So it actually changed her life in a lot of ways. She couldn't even run before, but now she's like totally mobile. So for breast conserving surgery, I can also select some patients for minimally invasive surgery, especially when the scars were meant to be in a very unsightly location. And it's the same thing, basically. I just want to remove it from the armpit. So for example, this is the tiny scar in the armpit region. So basically, I look towards form restoration, scar minimization, function preservation, and quality survivorship, because all this really should go beyond oncological cure, so that incisions can be kept small. So I first started this procedure in 2019 in Singapore. We were the first at the time, and I have gone on to teach and impart this skill to many colleagues in Singapore and around the world. So I think this is something that's very established as of today. So just moving on, the next message, final, is to live well. And I think we already know how to do that. We optimize our weight, exercise, avoid alcohol. If possible, try to have babies try to breastfeed, but this is not always within our control. Instead of just waiting for something to happen, try to do at least a breast examination once a month. Even better if we can do a mammogram to detect even before things can be felt, so we can nip problems in the bud. So basically, instead of just waiting for a mess like this to happen, let's do some screening, okay? So do breast examinations once a month. Basically, this is a summary of how that should be done. We should touch every part of the breast and make sure there's no nipple discharge. And if there is, definitely alert a doctor. But most importantly, if we can do mammogram screening, instead of diagnosing problems here, let's diagnose problems when they're far smaller, even smaller, or sometimes not even visible. For example, this is really just microcalcifications, a precancerous condition. And if we had diagnosed it at this stage, we don't need a resection that's bigger and bigger. And how do I remove the microcalcifications or small lesions that look indeterminate? It's just a vacuum-assisted keyholes technique. It's just a needle biopsy. I put it in. It's a tiny 3 mm cut. The patients can be done under local anesthetic or just sedation. They're super comfortable. And basically, I just remove entities that are either benign and changing or maybe precancerous, and that's the end of it. We never even have to talk about cancer. So how do we get mammograms done? Basically, I know a lot of people are worried about this compression, but it's kind of necessary because we need to distribute out the breast tissue properly so we get good films. These are the films that we want to get. And basically, the compression is necessary so that the image is good and we can give you a good answer as to what to do about that. There are many ways to make it less uncomfortable, and as a specialized unit, we're able to work through that with you. And people ask me, is this dangerous, right? Is radiation dangerous? And the answer is no. Mammogram radiation is really quite subtle compared to a lot of other things, including our natural background and our exposure to radiation. Patients ask me if I have implants, can I do this? Yes, but in specialized centers, and the implants need to be pushed to the back. Now, also be wary that implants don't mean these kind of illegal silicone injections, which is not ideal, because when one injects themselves like this, basically it's super hard to find cancer down the line. So if this is ever something that you heard of or offered, don't go towards there. The last thing to understand is your personal breast tissue density. Every woman has a different density, and most young women are going to be denser, meaning they have more fibrous glandular tissue as opposed to fatty tissue when they're older. So basically understand your density, because sometimes one mammogram may not be enough. We may want to do something like a 3D mammogram, for example. So on this side is the 2D image. On that side, a 3D mammogram is like taking many images at the same experience that you take a 2D. And we can scroll through the images to see that, oh, actually, that's not a mass. That's just density that's happening in that space. So it gives us more information. And this is almost the current gold standard right now. Or sometimes the doctor may say, do an additional ultrasound or MRI for certain cases, and they should have good reason when they explain that. Lastly, the message is most women nowadays are not really screening in Singapore. Our screening rate is only there like 30-ish% to 40%. So we need to work a little harder. And by the way, there is a mammo bath on site today. So if you are interested, please go down and see it. Okay, so lastly, when you see a specialist, they should be able to put all this information together, propose exactly what you need, whether you're average risk, intermediate risk, or high risk, explain to you guidelines and the implications. And so at the end of this, just make sure that the take-home message that you have is do these 5 things, be aware, understand your personal risks, live well, do regular checks, and please do seek medical attention early, because life's peachy sweet if you test, detect, and treat. So I am at the Mount Elizabeth Hospitals, both Orchard and Novena, at Breast Surgery Care Partners, and this is me. Thank you very much for your attention.
Thank you very much.